everybody. Welcome again to another VITA Learning webinar. Today we have Mr. Mark Wagenseal, extraordinaire.
Good
Mark,
morning.
how are you doing today?
Super duper, especially now that I'm here online.
There you go. So show the folks the snow that you have outside your window.
Oh, okay, let's do that. I can show the snow. It snowed. We had like, how much? 6 centimeters. So it's our winter wonderland.
All right.
Yeah.
And that's what town?
In Edmonton.
Edmonton.
And now, hockey makes better sense now, especially now that the Oilers are winning and there's snow outside. Everyone's excited.
Nice. Well, that's good to hear from you. If you get snowed in, that's okay because you can still be able to do the webinar.
Yes.
That's the most important thing for today, right?
Indeed.
At least for us, right?
Yeah.
For the customers that have joined us today. So, thanks everyone for joining us. We'll get moving here. Just a couple things that I want to go over. First, everybody's phone, you're on mute. If you do have a question at the end of the program, you'll be able to type in your question or throughout the webinar as well. Use that panel that's located on the right-hand side of your screen. Go into the question box, not the chat room, but the question box. Type in your questions, send those. If it's something that we need to answer right then, I'll interrupt Mark. He always enjoys me when I interrupt him. Put the stop sign up. And we'll ask the question. If not, then at the end, there'll be plenty of time to answer questions and elaborate on any of the ideas and thoughts that Mark is going over. So we will record today's webinar. If you want to wait a couple days, we'll post it on the VITA North America YouTube channel. Mark has probably, 20, 30 webinars recorded that are up on that website along with other programs. So please visit us on the VITA Learning website or the VITA North America YouTube channel. And then we have today with Mark perspectives on denture occlusion. It's more than slapping teeth together. So everyone should know that break out of that cookie cutter format that you might be in a slump doing. And so Mark Wagenseal is a denturist. He's a VITA Global certified trainer and management consultant. He's a licensed denturist and a technician with over 35 years of experience. So he's going to be coming from the point of a denturist technician. So a very good perspective that you can ask questions about on the flip side of the coin, the clinical side as well, that Mark will be able to help you out with as well. Mark owns and operates a clinic, Heritage Denture Center in Edmonton, Canada. That's his own clinic denturist practice. Mark has spent his career focusing on how dentures integrate in the mouth and body. He inspires a unique awareness of occlusion and professional growth of technicians, dentists, and other denturists. So Mark, welcome again. And we will make you the presenter. We'll give you all the control you want to have.
All I've ever wanted, yes.
Today.
I get to be the key master.
You are now the presenter.
Nice. All right then.
And I'll let you know when I see your computer's up. And looks like we are on the way. There we go. All right. I'm going to disappear, and I'll just be in the background.
All right. Jim's the hallway monitor. Good morning. Hello, everybody. Welcome. Woohoo! Thank you for spending time with me. Thanks for taking an hour and a half out of your busy days. I appreciate it. This is about supporting our professions, moving our professions forward, supporting you while you are supporting a doctor and or the patient directly. There's always a patient at the very end, and we are there to support them and be a superhero for them. so that they can eat and have a quality of life. Thanks for taking time. Thanks to VITA North America for their kind support of our professions. Thanks to Jim and his team for all of the hard work and behind the scenes efforts that they do to put on these presentations. We always appreciate your feedback. So after the webinar, usually a day or so after, you'll receive an email. Please take a moment to write down your thoughts and to provide any other ideas or such. VITA would like to hear from you because that helps them in their planning and helps them get a bead and a feel for industry and what's needed. So we always appreciate that. Thank you. So let's begin our journey. And I have a little bit of a PowerPoint and some videos and some things to show you. So we're going to get right to it and have some fun today. And so this is about perspectives on denture occlusion, and it's more than slapping teeth together because we do not slap teeth together. Woot woot. So this is really cool because I love it. I get to talk and interact with denture-minded professionals and have your attention. We all deal with dentures, and dentures are hard. They're hard to make, and they're hard to fit in the mouth. And it's not easy, and it's not slapping teeth together. And I love it because it's cool because I get to interact with you and denture-minded professionals as we, again, try to move the denture side of things forward and learn and grow. And that's what this is about, is sharing and sharing ideas and experiences to make ourselves better and to try to remember situations when we're in the weeds with a patient. So our common denture issues that we face clinically are denture teeth chip, break, and pop off. You can't chew well with a new denture, traditional or an implant, even digital. The new dentures are more loose than the old set. So in the early part of my career, it was funny. I'd get complaints about how the old teeth fit better than the new teeth. And I'd look at it and go, my bite's right, and everything's good, and the extensions are good, and I would just be frustrated at the end of the day. Multiple relines with no success. The denture base is breaking on a traditional or an implant denture because of the torque. Food collects under the denture, but no reline would be warranted in this matter. And what I mean by that is we typically check it, we take our index fingers and we push on the denture, and if it's not rocking and rolling on the gum, then it doesn't need to be relined. So it's usually other issues that cause it to become loose, or the patient to interpret that it's being loose. But then we misdiagnose it and we reline it too quickly. And if we're not careful, we can really damage a denture by relining it when it's not necessary. Locators wearing out after a few months. This is common. They should typically last anywhere from a year, year and a half. And if you're replacing them every 2 to 3 months, there's a problem. And so we would always just, again, look to the locator as the problem, but it's actually the way that the teeth are operating and how the teeth are interacting. Typical, again, soreness, pain, and discomfort, and then a temporary denture is preferred over the permanent. So these are kind of common denture issues that we see clinically, and then this ripples forward and into the lab as well on work order forms. So this is complaints. This is part of our responsibility with dentures, and we accept this as part of building dentures, is that we hear complaints afterwards from a patient. And typically those complaints are coded as an adjustment. So then clinically we would see denture adjustments for patients, and that's when we hear the sort of the complaints or the negativity after the dentures are made, and then we're trying to correct those and make the patient happy. You have to appreciate that these complaints and common issues that we deal with build up over time. So in a laboratory environment, when we see repetitive issues come to us every day, and the same types of issues, it causes us stress. Clinically, same thing, where we see it build up over time, and we're dealing with anywhere from 4, 5 to 20 adjustments a day. It builds up depending on, of course, on the size of your practice. And these things wear you down over time. It's stressful for us, laboratory-wise or clinically-wise. We appreciate that it's part of our job, but it causes us stress. And this repetitive stress builds up over time, and it can lead to burnout for us as denture professionals. Professional happiness. in 2019, the World Health Organization listed burnout as a disease, and it's categorized as feelings of energy depletion or exhaustion, increased mental distance from your job, feelings of negativity, or this one is big, cynicism. And when you go to conventions or you interact with our colleagues, you hear the cynicism. You know, the dentist doesn't do this, or I have a crazy patient, and these types of things that, you know, we commonly hear of how we just sort of brush it off. But we get cynical because it's helping us cope with the issues and the problems that we face daily. It also then has the rebound is reduced professional efficiency and a disrupted sleep pattern. So I want to touch on that because we need to discuss our mental health more in our profession, and especially on the denture related side of it. It's important. A major sign of burnout is if you go on a holiday, even if it's a long weekend, you come back and after a few days of work, it felt like you were never on a holiday, then you're suffering from burnout, my dear colleagues. So number one is to identify it. And then my goal in the next hour and a half is to give you some denture-minded perspectives on how to reduce your stress at work on a denture-related issues. And I always encourage my dear colleagues to always also look for supports within your community and within your city and state or province, as well for good mental health support. We are certainly talking about it more as a society, which is good, and supports are available. My goal here is certainly to only talk about the denture side of things and what I've done over the years to try and make things better for me from a denture perspective, because I've experienced it in my staff. And meeting denture professionals worldwide. I want to zero in on my staff because, again, talking to colleagues, you have to appreciate, especially from a dental office or a denture clinic, patient phones, and then what's the first person they talk to? Your receptionist. And then they're upset. They need to come in and see, me or the doctor for an adjustment. And then, we're busy, or the dentist office is busy. And so then the receptionist says, well, I can only get you in, next Tuesday. And then, of course, the secretary gets an earful from the patient, and, on and on and on. And that's hard on them as well. They're trying. And even as a dental technician, for those of you that are listening, you have to understand, like, it's hard on the receptionists when they have to deal. And when you talk to a dental office, depending on the dental office and how they're geared, so if they do a lot of dentures or not, just specifically they deal with denture adjustments. And then the patients can get quite cranky with the staff. So then my secretary would warn me and go, geez, yeah, Mrs. Smith is coming in. She was cranky with me. But then Mrs. Smith comes to my office and is sweet as pie to me because now she's here. But was cranky to my secretary on the phone to get in. And sometimes too, then Mrs. Smith ends up cranky with me as well. So my goal is to share some of these experiences because you have to appreciate it's hard on your staff, and even on a dental technician end, you get the work in, you get the work order again, and you just lower your head and go, geez, again. And then, your poor staff are trying to fix it. And it's difficult because the disconnect is because they're not looking at a patient or seeing what the patient is experiencing firsthand, and it's hard. So again, this is me wanting to share my journey with you and help it on the perspective of denture occlusion. So hi, I'm Mark. I'm a denturist and dental technician. I've worked in large dental labs, small dental labs. Now I own my own denture clinic and office and dental lab here. And I first off want to say that I love what I do for a living. It's the right path for me. I love dentures. I think they're awesome. I'm 52. Next Monday is my birthday. I'll be 53. So it's been 35, almost 36 years now of my life building dentures and seeing patients and being involved in the denture profession. And again, I love what I do for a living. It's been 3/4 of my life now building dentures. And that's what I want to share with you is my journey and my aha moments figuring stuff out. So dentures are like a tort. They're made up of a lot of slices. And so I'm going to peel back and take out some of the slices of a yummy tort. And slice number 1 is you have to consider the central nervous system of a denture patient. So that means the central nervous system learns and functions on patterns and repetition. So when a patient has an old worn out denture and you're replacing that denture, that has a pattern to it, and their brain has a pattern to it. So it's much like when my wife would get a new heel put on her high-heeled shoe and then she wobbles a little bit. That's because you've changed how the shoe and the foot integrate, and then you've changed her gait or her walking pattern. So it's the same thing here. We have to appreciate that a new denture changes what the brain is interpreting. So regardless of the denture you make, regardless if it's on implants or not, it's something new to the central nervous system. The central nervous system is subject to degradation and due to age, health, and medicine and medical concerns. So as we get older, our central nervous system loses its, I'll call it tonality, and it's not as sharp. Our neuromuscular system isn't as sharp. So we just have to remember that the denture fits inside the body, but the body is starting to wear out and it's not as sharp or crisp as it used to be. Yet the denture has to function in that environment. You have to remember there's no nerve into the denture. And that's something that I remind myself often. We have to remember there's no nerve into the denture. Whether you're the technician on the bench or the doctor or the denturist, you have to remember that patient can't feel their teeth touch together. There's no concept of that. They don't feel it. What they feel is they feel the hydraulics of the denture. So that's why I remind myself that they don't feel their teeth touch. So how do they feel? Well, they feel the hydraulics. So when they touch together in centric and they swallow, so when you touch your teeth together in centric to swallow, that braces the teeth together. So the muscles have something to brace against to facilitate the swallowing protocol. They feel that hydraulic pressure on the ridge. So then when you say just touch your teeth together, they're looking to reproduce that hydraulic pressure. That tells them that their teeth are together gently. So they're looking to reproduce that hydraulic pressure. Then that hydraulic pressure changes upon chewing. So then when you chew, they feel more hydraulic pressure on the ridge, and depending on what side they're chewing on, they'll feel more pressure left to right side. And then that's how they can tell that they're eating, because the denture puts down more pressure on the ridge. So the central nervous system picks up that pressure change and the hydraulic change. So then when we build a new denture, you have a new impression, you have a new fit, you have new teeth. So what happens is that changes partially the pressure that it's put down onto the ridge, especially if one opens the vertical dimension and lengthens the masseter muscle, there ergo lengthening the face, you change things. But remember, there's no nerve into the denture. So that kind of comes back to when the patient says, well, my old denture fit better than my new one, is because now the teeth are clashing, but they can't feel it. And then they're not able to tell you that's what's happening, and then we misdiagnose that. So I'm giving you this perspective to help you figure out when there's a problem, and a repetitive problem that you're faced with, regardless of whether you're a technician or a denturist. If you're faced with that repetitive problem, okay, this is some of the background. We have to think of the person this fits into. And I say this a lot now in my practice. This tells us a story. The denture's telling us a story. The patient is telling us a story with them feeling and functioning with the denture. We have to now jump into their head and try to decipher that. So the number one thing was, remember, there's no nerve into the teeth. Number two, they feel with hydraulics. And then, of course, remember, there's that pattern. So at a certain height, the muscles get used to functioning at a certain height and certain ability. So that's why, again, what buggers us up is a denture patient's feeling of a denture influences how they feel that bite rim, the wax trying a new denture or an implant denture. So this was the big one where a patient will come in and you put the wax rim in their mouth, and then you tell the patient to bite or close, and then they thrust their lower jaw ahead. And then we go, no, just relax your bite. And then they thrust their lower jaw ahead. And we go, no, just take the tip of your tongue to the back of your throat. And then they stick their tongue out at you. And it's like, okay, just bite. And if you have, just from a technician's perspective, if you have a doctor that seems to get a lot of bites that are quote unquote wrong, this is what's happening. The patient, they have a certain feel with their existing denture. You put a wax rim in someone's mouth, that's not the same feeling. It's not the same. So the brain doesn't know what to do with it. It's confused. And that's why they thrust their jaw out or such when the dentist tries to take a bite. So now, from that perspective, I make a wax rim look and feel like a denture. So the base of it is really, really hard wax, or you can use a shellac that's hard and smooth like a denture base. And then I carve the wax rim like a denture. I don't make it 5 millimeters thick in the anterior anymore. I make it 1 millimeter thick because the denture is 1 millimeter or so thick in the anterior. If you make a rim that's 5 millimeters thick, you've protruded the tongue, your bite's off. So when the rim goes in and it befuddles and confuses the central nervous system, that's why you get wrong bites. Now, for all the denturists or doctors that are listening and joined us, that's also what's happening. Resculpt the way you do the rim, and stop using the word bite. Bite is, by definition, means to actually bite through and cut through something. It means it's hard and strong. Bite. Arf. Stop using that word. That was another aha moment for me when I started to change the commands that I gave a patient, because I spent a lot of time trying to figure out a denture patient and why I was facing these issues commonly every day in the office. So I would use the word now swallow. Swallowing is subconscious. It's a subconscious command. It is not a hard or aggressive or hard word. Swallowing will always take them to their physiologic centric, just as I swallowed now. So you make a rim that's fits and is carved like a denture, and now you use the word swallow. You'll watch the errors in the bite go down. So that's a tip for all the technicians now, and especially when you're dealing with the doctors, to reshape the rims and to have the doctor use a different command word. And now for the denturists or the doctors that are listening, please use a different command word and use the word swallow. And also then when you're building it yourself, just reshape the rims differently. So that was a big aha moment for me, and that's really helped me and cut down on those bite errors and registration errors now, because number one, I make the rim look and feel like a denture, so it doesn't confuse the central nervous system anymore. And number two, I use a different command word. Slice number two, we expect a patient to accurately find centric each and every time. So we set the teeth up on an articulator, we go, my bite's right, and then we expect, in most cases, a senior citizen to accurately reproduce centric. And then that's not possible. So we expect them to bullseye land that thing every time. Whether it's digitally or traditionally or whatever, it doesn't matter. You're asking someone to bullseye land centric and be accurate on it without any degree of error. And I'm sorry, but that's not possible. It's not possible for the muscles to be that accurate, the central nervous system to be that accurate, especially when they can't feel their teeth. And especially as we age and we've got the degradation of the central nervous system and our neuromuscular system. So that's the other aha moment for me was when I would always say, and you hear our colleagues say, well, my bite's right, my bite's right. Well, okay, you don't chew in centric is number one. And number two, they can find centric, but even if there's a slight error in centric, you can't see it. So the patient's biting together and they think it feels fine, but again, if there's that little shake in the denture that we can't physically see, that's why it's always loose. So when you don't find centric right, you hit and slide. Again, sharing with you my other perspective was they can't feel the teeth hit and slide into position, even if it's a minute amount or it's the width of a human hair. With natural teeth, I can feel a raspberry seed or a piece of hair caught in my teeth. A denture patient can't. And when that happens, that influences your bite. And so now the hit and slide causes the rock, causes the hydraulics, causes the stress. So it rocks the denture, causes the food to come underneath. We misdiagnose that as a reline. It causes the stress on the denture, which breaks the denture. We fix it, but it still breaks because we haven't dealt with the hydraulic problem. Especially if this sits on an implant, now that it takes the denture off the gum even more, or especially if it's an all-on-4 and all-on-6, now you've taken that denture off the gum. And now they've lost that sensation of the hydraulic change. So now all that's left is muscle memory to find your centric. Well, how accurate is muscle memory? So, okay. Yet we set up teeth to have bullseye landed centric. My other aha moment now regarding that was freedom and centric. So that's the flat area in the central fossa that opposes, flat center upon which the opposing cusp permits a degree of freedom. So that means you can set the tooth into centric, yet in centric, it can slide horizontally and vertically. So sort of, you got to imagine north, east, west, and south, about 0.5 to 1 millimeter in centric before going to eccentric movements. So before rising up the guiding planes of the teeth. That's freedom in centric. So we all have this with our own natural teeth because nature saw that we couldn't reproduce centric all the time. So the real life example here is us touching our teeth together in centric now. And now in centric, I want you to wiggle them in light centric. You can wiggle your teeth in centric before they go eccentric. It's slight, but it's there. That's freedom in centric. And freedom, my dear colleagues, is good. Freedom is good. And so what I realized was that's what helps control and stop the hit and slide, because it's impossible then for someone to go through a chew cycle, eat, and bullseye land centric. So they hit and slide into position, but they can't tell us that because they can't feel their teeth. Now, by incorporating freedom and centric into dentures, I'm giving them a little bit of a helicopter pad to land in. So it doesn't have to be perfect. And all of a sudden now the denture doesn't rock. The denture doesn't tip. The denture doesn't walk like a penguin. It doesn't tip and move. It's reduced the hydraulics, reduced the stress fractures and breakage of the denture. So that's why I bring this up as part of the slice, was because, again, they can't feel it and we misdiagnose it. And again, we want to be careful because especially if you're on an all-on-4 or an all-on-6 or such type of implant where our responsibility is to protect the TMJ from these little micro vibrations and errors that would slowly wear down the joint. It's like, again, stressing out your knee or your hip. So this is what it looks like on a denture tooth. So we can wiggle side to side, and that is the freedom and centric. And then I'll do the eccentric movements so you can see that. So the opposing cusp sits in the fossa. And now we have that little bit of wiggle room within centric for it to move before it goes eccentric. So those are freedom and centric denture teeth. And that's what they look like, and that's how they would function. So this is me holding a denture with freedom. So I apologize because this is proved to be a little bit hard to do by holding it and trying to do with the camera. But you can see me shake it in centric, where I can take the denture and there's a little bit of movement in centric before I go working and balancing eccentric movements. I can take the denture and wiggle it in centric. So that's what it looks like with a full complement, is I can wiggle the plate back and forth, and there's that 0.5 millimeter of wiggle room in the denture. One of my most pertinent aha moments in my life was realizing and learning that not every denture tooth or digital design now with digital technology has freedom and centric. And I put the here because it's not talked about. It was hard for me to research because I had to really go to the research and development department of dental companies and talk to the people that have really intimate knowledge about what freedom and centric is to find out if their teeth had it or not. Most denture teeth do not have it. They hold together in centric, it's locked into centric, but they work in balance, but there's no freedom. So again, you're asking someone to bullseye land centric. Well, I'm sorry, it's not possible. And that really helped me understand why I was dealing with a lot of problems during the first 5-10 years of my professional career, and why those problems weren't going away, because even though my bite was right, and even though I'd remounted and checked working and balancing contacts, the bite was locked together. And so then I started to research, and then found that I need to have that little bit of centric play in it. And my adjustment rate and complaints dropped dramatically. It was an eye-opener for me. And that's why I say this was probably one of the most biggest aha moments of my professional journey, was realizing that not every denture tooth has freedom and centric. There's a handful of them on the planet that have it. That's how few have it. Now you're sitting here and you're going to ask yourself, is he going to say which ones have it? And I'm going to say yes, based on my knowledge of what's out there today. VITA Lingoform has it, MFT has it, and Physioden's posterior teeth from VITA have it. That's it. All of the other tooth lines from VITA do not incorporate freedom and centric. Ivoclar Veneris 2. They have it currently, and that's the only tooth line that carries freedom and centric at the moment from Ivoclar. And sorry, and on VITA, Vigo has it, so their digital line has it as well. Ivoclar's digital line is based not on the Veneris line, to my knowledge. So that's it. There's a handful of product. Merz Dental from Germany also has it, but it's a little harder to get Merz Dental teeth here in North America. So their Artegral teeth have it. And really that's about the list of denture teeth globally that you can get it on. I always ask for everyone's understanding that if I miss one or two here or there, then thank you. Please email me and let me know, because it's hard to keep track of this, and it's not that we talk about it. That we don't talk about it often, and it's not publicized often, so it's hard to know whether or not the tooth has it or not. You have to do some serious research to find it out. And that's been my journey about who has it and not. So slice 4 then was understanding, okay, my bite's right. Okay, I'm using freedom and centric denture teeth now with a little bit of wiggle in them, but now there's a chew cycle. So this is a video of natural teeth, and the patients are eating. So the first is an apple. So this was filmed in the University of Strasbourg, and I want you to show, and I want you to see that the jaw actually moves at a teardrop. It's curved. Look at it. It's at an angle when they come up and close into centric. See? So everyone has this unique pattern and this closure pattern. It's like everyone has their own walking pattern. Now everyone has their own chew pattern. And if you look close enough, you can actually see the teeth touch, slide that little bit, and then open. Okay, most of the function is on the posterior teeth. It minces food. So this was an eye-opener for me professionally when I saw this video. You know, this is an old video of this happening, because I started to realize that the denture teeth, natural teeth mince food. Okay, and it's crushing it. It's not milling it. And I'll talk more about this in a moment. Look at the chew cycle on this patient now. Watch. And what do you see different? You see how it's more vertical? So the other ones were more horizontal in nature, like a teardrop. This is more a vertical teardrop by nature. So now the teeth can be set differently. So what I try to do clinically is I try to figure out the person's chew cycle and then set teeth within it, because the chew cycle influences interaction and function, anterior and posterior. So that's what matters. There's a cycle here. Let me get my little laser pointer. There's a cycle here. And then what happens is it's the hit and slide on the guiding planes here that causes the denture to slide into position. And so we need the freedom and centric. Then you need to make sure that the guiding planes are cleared depending on the chew cycle of the person. So chew cycles can be defined as being flat, ovoid, oval, or teardrop. So typically what I've learned is flat, they're going to be more horizontal. So I need to really watch the guiding planes on the new denture. Oval requires a little less freedom and centric, but you got to again watch the guiding planes. So a standard teardrop is sort of a regular setup where things can function like you saw in the video, where that 1 millimeter freedom and centric should be enough to allow that there's no hit and slide and things work okay. So if you're in the weeds as a dental technician and you have a case that there's been nothing but trouble, again, it's telling you a story. Then you have to go to the doctor and say, look, we need to talk about the person that this is functioning inside of. Tell me about them. How old are they? What was the denture like before we replaced it? Was it really worn down? Tell me about them. Are they hunched over? Do they have tremors? Are they old and frail? These things will influence their chew cycle, and then you can make those corrections in the lab. And that's what I do here clinically is I observe a patient, I observe what their jaw does. And that's now sort of another little slice here is that my perspective on occlusion is I've identified a chew cycle. So I either watch them or I have them chew nonstick gum, or what's worked for me is green pepper, cucumber. And then I have the patient speak days of the week and months of the year and in their mother language other than English. The reason being is because the building blocks of a language will contain the phonetic building blocks of that language. So the A, E, I, O, U in English and the consonants. And that means that your jaw has to position itself to be able to pronounce those words. So this is a patient and watch them. See their lower jaw move? See it posture? And it really pops out to her left. See it there? So what would happen is I would hear complaints early in my career going, well, the teeth are loose after I talk. And I would always go look at the extensions of the denture and think it's an extension issue. Actually, it's the teeth hitting. And it was the teeth hitting while the patient's trying to function. And then it would slowly loosen while they're talking, but it wasn't clacking enough. So that was the dead giveaway on porcelain teeth because they would clack right away. So then the patient would say, well, I hear clacking. But then that means that they were binding. And so now with acrylic teeth, you don't hear that as much, but then the patient would say that. So now I see when I examine a patient, I can now set the teeth to function more to that patient's left side. And I can make sure that the guiding planes and such and the anterior teeth now function more to the left side. And so I colored the teeth for this patient. She was in a lecture of mine years ago. And again, 66. Watch her jaw move. So wasn't it interesting when you watch her say 66 and she shakes her head? So anytime that I would have anybody in the course say 66, you automatically shake your head while your jaw is posturing. It's just what our brain does. And so what I'm trying to do is we would use words like 66 and a wax try-in to look at the aesthetical value. But now I'm using those cues to help me find the movement of the jaw. Now, this video was sent to me by a doctor in the US. Now, this is a complete upper denture and lower cast frame free end extension partial. And they're having the patient eat. And they opened them up and they're filming them eat. But look, you see the chew cycle? So look at this guy. He's chewing, and again, that chew cycle exists, denture or no denture. So now the denture teeth, remember, oh yeah, Mark, my bite's right. You don't chew in centric. Now, as that patient comes down and slides in, that's where the hit and slide occurs. And now there's food in the way. So that's why you have to clear it out. Now, this is awesome. This case is like a month and a half old. It's a lower implant retained denture and a complete upper denture. And you can see, look at the wear pattern on the teeth. So you can visibly see the wear pattern here. Look how worn down this sucker is. So the teeth are flat. So she comes in and everything is sunken in. She's frowning. She said she can't chew well. It's dull. And then I'm also asking her about her health, and she comments to me that she does use a laxative to help, because you have to remember, if you're not chewing your food well, the rest of your digestive system is not going to work well. And so you'd be surprised how many patients that have, I'll use the word problematic dentures, and dentures that don't fit well or worn out, how many of them are on a laxative? Because now they're not chewing their food right. So the whole thing becomes problematic. This is where the, oh, my new denture is looser than my older denture comment comes in from patients, because then we would rehabilitate this case, put in new teeth, and they're sharper with cusps. But I want you to watch how she speaks, because then the teeth would bind against each other, interfere against each other. So watch how she speaks. Watch what her jaw does. You see how much that moves? Look at that thing. Now you wonder why this woman would have trouble adapting to a new denture when she postures like that already. And now I know that the central nervous system has a pattern, and I remember it has a pattern, and it's going to try to repeat that pattern. And now her jaw relationship, so her chew cycle and function cycle, is not going to change with the new denture. It's going to be the same. So now this is her new denture. So I built a new denture. So again, remember, it's implant retained on the bottom. So it's not going anywhere. So then that's where you run into the chipping of the teeth and the teeth chipping and stuff. She's been back for one adjustment. That's it. And no chipping anything. So what I did was I gave her freedom and centric, and then I cleared out the guiding planes of the teeth so she can function on the left-hand side. Watch. So that's my perspective on occlusion, and how now I've tried to get a grip and an understanding of how the patient functions to then make those changes in the lab when I set the teeth, so that then I reduce my adjustment rate. I've built a denture that's more functional for the patient because it's built to them and their needs and quirks and functionality. So when I share with you my perspectives on denture occlusion, this was another aha moment for me, was setting teeth within the functional limit of a patient, not the articulator, not the textbook of what that person is. Her jaw's posturing. This isn't changing. This is who she is. So now I have to set teeth within this pattern, and I can. And that's how I've done it. I've done that by using freedom and centric denture teeth. Then I adjust the guiding planes, clear it out on the sides that's necessary. So now, for all the denturists or doctors that are listening, that's been the clinical thing that I've done and how I do it. And for the dental technicians listening, understand that this exists, and on every denture you do and get function and make in your lab and send out every day, it goes into somebody, and these things are happening. So what you can do to help the doctor is use freedom and centric denture teeth. Know that this exists, and that you are trying to, again, just make the denture a little bit more adaptable to the patient. Now, I've tried to, again, figure out what those things are for the patient to adapt it to. So as a dental technician, you don't typically see the patient, so you're not going to know what it is. So then just let it leave the lab with some freedom and centric, and you try to do some tolerances, and it's going to fit better. And then as a dental technician, what you need to do is to call the receptionist, track the adjustment rates on the dentures, and then when you say, for example, do a test case with freedom and centric denture teeth, and you track and say the adjustment rate dropped, then that also, you communicate that to the doctor and say, look, this is what we're doing in the lab to help support you. Because I want to be clear, adjustments are expensive. and they're stressful. So what are you trying to do? You're trying to help the doctor, you're trying to help their stress level, their staff stress level, and you're trying to help your own when it comes back in the box with the work order again, and there's problems. So, and for the denturists and doctors listening, it's the same now because we're dealing with the adjustments and trying to fit them in our busy schedules. When you get a hold of that adjustment rate and you can get it to 0 to 1 consistently, that's a big deal. It's going to free up our time and our stress level clinically. And I can say that I get mine down to 0 to 1 consistently. It's not perfect, but it's 0 to 1 consistently. And it's been an eye opener for me. So this is now trying to, again, set the teeth with freedom within a chew cycle, watching the hit and slides on the guiding planes. So I'm going to tip my hat here. I am less concerned now about true working and balancing on an articulator than I am about how this works within a chew cycle and letting it flow within a chew cycle. I've rethought occlusion, and that's again why it's titled Perspectives in Denture Occlusion. You don't chew in centric. So what's our normal? Well, our normal is working and balancing occlusion. So what working and balancing occlusion and what we're taught is that when the patient goes left, everything would work and balanced against each other to aid in the stability of the denture. So you have the working side and now you have the balancing side, and then together it would look like this. So this is what we're taught. Pardon me, this is what I was taught. This is what I left school and started to treat patients with. And then ran into the problems and went, well, wait a minute, my bite's right. And I'd remounted and working and balancing. And what I realized is now that you see this, it goes to show you, does this really function like this in the mouth? So I want to zip out and go to this video to show you on an animated scale, bilaterally balanced occlusion. So then the idea behind it is that this would, in that chew cycle, so you can see the animation is following a chew cycle, but now it has to perfectly line up that the working and balancing would be even in that chew cycle. Now stick food between the teeth and expect that to happen. It can't. And now you're expecting the left and right condyles and condylar angles and Bennett angles and all of these angles that are in our skull to perfectly work along with the disc and the head of the condyle, that you're able to have perfect contact in your teeth in this motion. I'm sorry, after 35, almost 36 years, that's not possible. Yet that's how we build dentures. And so for me, this was my, again, aha moment and perspective that I went, I'm not going to worry about how this working and balancing is going as much as now how the teeth function within that chew cycle. Because to me, that's far more important now, what's happening in that chew cycle. So that's why I wanted to show you that working and balancing perspective video. So now you have to think, you're really, what's the patient's normal versus working and balancing? So again, that lady that I showed you, this lady, do you think she's working and balancing when she eats, when her jaw likes to go out and favor her left side? She's not working and balancing. There's no way that's doing that. So that was my perspective. So in the lab, this is what we do. We check like this. So this now emulates what the working and balancing concept is and what the animated video of working and balancing is. This is what we do to achieve that in the lab. What I want you to do is I want you to do this. Think of a chew cycle and move the articulator like a chew cycle. Okay, left and right. Start to use the articulator really to your advantage, because regardless of the articulator, there is a conceived Bennett angle and condylar angle. It's going to help you try to move in a similar fashion of a patient. The more expensive articulator you have, certainly the more precise it is. But the fact of the matter is I want you to start, please, the technicians and the denturists, everyone that's listening, please start moving your articulator like that. Because now what you're doing is you're letting the teeth, and you're trying to find that hit and slide. You can see the hit and slide. I'm doing this on purpose so you can see it. Okay, but now there's no hit and slide. So I'm trying to emulate and have the teeth function within a chew cycle, adjust the guiding planes out as required, and I'm not really worried about working and balancing anymore. I'm worried about how the teeth function within my understanding and estimate of a patient's chew cycle. Now in the lab, when you don't see a patient, then I would always overcompensate, meaning just make sure that you've got a good wiggle in there and that it can be done, and that you're trying to, again, watch those hit and slide contacts. So this patient, I just want to show this video quickly. Watch her speak and her jaw move. You see her jaw move in there? Now watch. You see almost a full tooth. You see about the, gosh, at some points you even see about half of her lower anterior teeth when she speaks. This is about my journey about getting out of my way and challenging what I was taught. And I'm thankful for what and how I was taught, but I built upon it then, because I was left holding the bag, standing in front of a patient with them complaining about why it wasn't working. And that's what I'm sharing with you today, because now I build dentures I never thought possible, because that patient, I buried the occlusion. She has what, 6-7 millimeters of overbite there, yet you can't tell that when she speaks, and it works when she functions because I have freedom in centric. I set the teeth to work within her chew cycle. I'm building teeth that I never thought I could before, because I make it work for her. So that was about challenging yourself and challenging what you think you believe. And that's how the chew cycle influences and changes how the teeth work. So going back to this video of bilaterally balanced, is that now I'm showing you and laying you the groundwork of my journey and questioning and watching patients that they're not going to chew like this. I'm more worried about getting the teeth to function within that chew cycle. And part of that is the anterior teeth. So I'm going to just load a different video within this. And I'm going to talk about how anterior teeth work. So bear with me as I get to this one. So that's been interesting. You bite into food, you tear. All right then. We bite into food and we tear it away. And so what's interesting is before we would check for protrusive movement, and then you would want end-to-end contact. I don't really, again, do that anymore. As you saw in the video, I actually am having lingual contact, so the lower incisal edge is going to come up and not go end to end or edge to edge with the upper. It's actually contacting more on the lingual slope of the upper anterior. Now I'm going to have balancing contact through the cusps of the teeth in the posterior from a balance perspective, but I'm not looking for that end-to-end contact much anymore because I don't require it for most patients. It's something that I was able to rethink anterior tooth placement, and now since I've been doing this in this type of manner now for a good 20 years, I do not get the same anterior tooth breakage or chippage like I used to. It's rare that we have anterior teeth break now in the office or chip in the office. It's rare, really rare. And so it was my rethinking of chewing and how it works, and then using teeth that allow me to do it. Unfortunately, I've tried other teeth that aren't freedom and centric denture teeth. It's just it doesn't work. So we have to do too much calibration and adjustment to the teeth, and that's why again I've sort of migrated to the VITA product line and why I use them now, because I don't need to tinker with them as much. And especially the lingoform teeth are made from acrylic glass. I don't need to polish them after I touch them because they self-polish. So it's been the time saver for me. They're quick to set up in the office, and then all I need to do is tweak them to the patient's chew cycle, and then I can just from a lab perspective, it's going to be fast as well, because I appreciate your technicians are working to a lot. Gosh, I remember going to labs, and there's some labs that I've seen where they have a cart beside them. There's 20 cases on that cart, and you're asking someone to set up 20 setups in a day. Geez, I'm scratching my head going, even me trying to do 20 setups in a day is going to be a challenge. And I've been doing this for 30 whatever years. I mean, I was just, yeah, I appreciate everybody's busy. You're trying to get it done. So that what I find about the lingoform teeth is that they have the 3-point contact. It sets in centric really quickly. I adjust the articulator now in the manner that I'm showing you. I clear off anything that I see, and then you can wax it up and be done. It's going to be fast for you. What you're just trying to do is calibrate it a little bit more in the lab quickly, so that when it leaves the office, it's going to sit in the mouth calibrated a little better for the patient. And what you're trying to do is reduce the adjustment rate for the doctor. Then the doctor's happy with you and your lab, so he's going to continue to use you and then tell his doctor friends to come and use your lab as well. And then from a perspective of a denturist and or doctor, when you can build dentures that you have 0 to 1 adjustment rates on, patients are happy, and then they tell their friends, and they're your walking billboard. You don't need to advertise as much anymore. So this has been, the ripple effect has been clear. The other video I just wanted to show, and I'll go back to this, is chewing. Cool video, hey. So the biggest thing here is the understanding of one, when we want to eat something, it's conscious. And then when we start to chew it, it becomes subconscious. So we don't think about it anymore, we just do it. And then that's when the natural rhythm and chew cycle takes over. And then so you bite off the food, then it's placed onto the posterior teeth, which crush it, doesn't mill it. Then from that perspective, the teeth are working within that chew cycle. So you heard them talk about freedom of non-working cusps. So that was my comment about the guiding planes. You don't want the hit and slide. That's what they're referencing in the video. You don't want the hit and slide there. So now that I've showed you the videos of people functioning and people chewing, and now the animated ones, this provides you the context and understanding of what's going to happen when the denture leaves your workbench, whether you're the technician or whether you're the denturist, how this thing's going to function in someone's mouth. And so then if you don't know the person and you don't see the person as a technician, all you have to do is just, okay, put some wiggle in it and do some chew cycle, please, and with the information you have available to you, and then send it out. Make some corrections, please. So these videos now lay the foundation of my aha moments to understand, how it's going to function in the mouth. So this is what I've learned from observing a denture patient, and I want to share this with everyone. General disposition. So is the patient happy or crabby? Because if they complain about everything, they're probably going to complain about your teeth. Their health, mobility, medications. If they're frail, then the teeth probably aren't going to fit as well. And so again, I say this to the perspectives of the dental technicians listening. If you get these cases back that are nothing but a headache for you, then remember, it's telling you a story. It's telling the doctor a story. You pick up the phone and go, who did we build this for? I need to know the person we built it for, because maybe it's over open. Maybe we need to close the vertical. I need to give them freedom and centric denture teeth and a lot of freedom, and watch the guiding planes, because it's the impairment of the nervous system and how then that affects the chew cycle of the person. And then I observe their arm and their hand, and you're going, what? So again, what do you see with this? So I look at someone and you can see arthritis. So is this a good implant candidate? You can see the skin is thinning, and I can see through it. So if the skin is thinning here, what's it doing in their mouth? So what's their oral mucosa doing? Because as we get older, and now the studies and studies that I can show you in other PowerPoints, is the cells in the mucosa actually become more elongated and they thin out, which is why the skin becomes thinner and you can see through it. So we know through study what's starting to happen to the epidermis and to the mucosa layers. They get thinner. You can see bruising here. So this tells me now that she's sensitive to what? Hydraulics. So now if she's going to bruise here, is she going to bruise in her mouth? Yeah, I'm going to think so. So I got to be careful more with her. I need to give her freedom and centric. But look at her nails. Look at it. Look at it. She's got glitter nails. I love it. She's 80 something years old, yet goes to the salon and get her nails done and gets her hair done. So it tells me she's still adaptive. She still can handle some things. Look at this patient. Look at this. You can see she's skin and bones. You can see through the skin, and look at all of the bruising. Well, this lady's frail. And if you'd meet her in person, you'd get it. Like, now that you look at this, you go, wow. So this tells me right away, be careful with what you do, how much you're changing it, what you're changing, how much you're changing the vertical. She's not going to be accurate because she's frail, which means the chew cycle begins and ends at centric, but you don't chew in centric. So she's not going to be accurate. She needs lots of freedom in centric. Look at this person. Well, that looks pretty good, doesn't it? So this kind of gives me the understanding of who I'm building it for. And I love this. You cannot separate the mouth from the person. So again, another aha moment. That's who this person is. And now you're trying to set teeth to function with them. So then that's, as I'm going to wrap up my PowerPoint here, Freedom denture teeth are designed like a mortar and pestle. They are designed to crush and mince food. Okay, that was what I see them do now. And all other denture teeth, so your 10, 20, 30 functional degree teeth, all are milling teeth. Look at this. There's no, look at how tight that is. And they have to mill like a mill, stone mill. That's how they mill. And you have to then touch together, slide, and then that's how you chew your food. You have to mill it. Well, no kidding, that's going to cause dislodgement and movement and manipulation of the denture base. You don't. I've shown you the videos now and my aha moments and my perspective on occlusion. You crush teeth. Excuse me, your teeth crush food. You crush it, okay, in a chew cycle. You don't mill it. So that was my big ha moment to understand that, and why now I've functioned the way that I do and build teeth the way that I do. The raw cost of our problems, the average adjustment rate for a denture is 2 to 5 times. And what does this mean? Is that most adjustments are about 20 to 30 minutes in length. So you're going to tie up chair time about 20 to 30 minutes because you have to clean the chair before and after. You have to come in, see the patient, find out what's going on. You have to exchange pleasantries and chit chat a little bit. And then you got to go fix the problem and then check it and such, then chart. So most adjustments are 20 to 30 minutes in length. If you charge, for example, $2,600 for denture, and the lab takes, say, $700. So in Canada here, our fees are broken up into a professional fee and a lab fee. So there's a certain amount of dollars allocated to the lab cost of the denture. So then you're left with a subtotal of $1,900. So that's how I'm breaking it out for analysis sake. So you've got the total fee, then the lab fee comes out for what it costs to fabricate the denture from a lab perspective. That left the office with a subtotal profit of $1,900. And then out of that, you have to take away your overhead. So if you're running at about 75%, maybe 80 in a dental office, 85. So then that left the office with a profit of about $475. 2 adjustments based on $100 an hour. Well, you have to ask yourself, are doctors charging $100 an hour or more for their time? And then you also, this was just based on their rate of $100 an hour. It's not even, it's less actually if you consider office overhead expenses. So you come back in at 2 adjustments. If you even just take the fact of what it costs to run your office every hour, doctors know what it costs them. So I'm showing you this, all the dental technicians listening, so you understand adjustments are expensive for the doctor. If you can be part of the team and part of the solution to cut an adjustment rate down, you're saving the doctor money and stresses and their staff stresses. So I'm telling you, they will be loyal to you. And to the denturists listening or the doctors listening, you cut your adjustment rate down. I freed up chair time. I'm not having to deal with it or get it into my day or not eat lunch or eat lunch on the fly, or my staff aren't getting yelled at because, so to speak, because a patient has to wait 2-3 days or a week to get in to see me. When I talk to denture professionals, I know some of the doctors are doing, get this, 20 adjustments to 40 adjustments a day, plus all the other work that they're doing. It's phenomenal. Imagine the drain on that. You wonder why we're burning out. So I bring this up because adjustments are expensive, and this is about getting a hold of it. 1 adjustment a day at 30 minutes is 2.5 hours a week. That's 10 hours a month. That's 10 hours of chair time that you're not making money, and that's stressful. And so preventing adjustment for all of us as part of the dental team that rehabilitates a denture patient, it's a big deal. So understanding the cost of adjustment was my initial aha moment that got me started on my journey of discovery here that I'm sharing with you. Because it was posed to me and I went in and counted up my adjustments And I had no concept of what I did every month or every week. And then when I started to realize, wow, I'm doing, 50, 60 adjustments a month or 100 adjustments a month, and what that meant to me as a practitioner, gosh darn it. I just said, gosh darn it. Yeah, I'm 52 years old. That was the aha moment for me, everyone. And that's why I wanted to share my journey with you about being a superhero to a patient, trying to provide them a better, efficient denture, toned and built to them, and the tricks and things that I've done to get us there. Because that's going to reduce your stress as a practitioner or in the lab, that you're not going to get these repetitive problems back, and it's going to be easier for you. So it was a big deal. So freedom in centric denture teeth, it helps address all of the common concerns that I've showed you at the beginning. It also has almost virtually eliminated soft liners usage in my practice. I don't use soft liners anymore. I don't buy it. If I have to do it, I have to outsource it to a lab, because I just don't even buy it anymore because it just stale dates. Because the occlusion, I've fine-tuned the occlusion to the person, and the dentures fit, and I don't need soft liners. So it's been an eye-opener, for me to deal with the damages and the results, and again, the stress that we face in and out doing our jobs. So before I switch over to the camera, please recognize burnout for you and your staff, the central nervous system and its influence on dentures and how it works and thinks, how the patient feels and how they feel with a denture and function with a denture, traditional or implant or digital based, they feel the hydraulics. Reading a patient and understanding them a little bit about then what you can get away with. So you're assessing the person. And then a chew cycle, and then setting teeth with it and moving the articulator to the chew cycle. That's been one of the big takeaways I want to leave you with today. It's certainly more than slapping teeth together, and it's thinking and working beyond, working and balancing. And that was my perspectives on denture occlusion, and again, not slapping teeth together, because this is about making it fit better for the patient and then reducing my stress load in the meantime. So my sincere wish is to support you and the patient that places their trust in you, wherever you are in the pie or the tort of the team that's looking after this patient. So this is my contact information. I'll put it on the screen right away before I switch over to the camera to show a few things before we wrap up. So you can text me or email me, and I will certainly support you. This is a whole lot of information, but these are all the sales reps. So in the video, you can pause it so that you can then contact the sales rep, a VITA sales rep in your area. Jim will also bring this up at the end of our presentation. And again, this is really cool because I love it that I get to talk with denture professionals and denture-minded people solely. So this was, again, my thanks and being a superhero. I'm going to switch out and jump over to the camera, so bear with me. And ta-da. Awesome. Okay. So here, I'll turn the light on and I'm going to snuggle in here. No, maybe I need to turn the light down. Okay. This is our good old actually, that's a little better without the light. Okay, 20-degree teeth. This is what we were all born and raised on, as I say. So this is our gold standard, really, of what we're trying to achieve. And then when you hold the teeth together, okay, voilà. So it's quite knuckle tight, right? You can see it. It's knuckle tight. The teeth are tight together. Okay. Again, like I showed you in the cross section, the teeth are really tight. And then what we would do is then you get your classic working and balancing occlusion set within these teeth. In centric though, there's no wiggle. They can't. It'll automatically go up the guiding plane because there's no freedom in centric on these teeth. So now, again, as the patient is chewing, we're trying to get that perfect lineup of the working and balancing contacts hitting at the exact same time while there's food in someone's mouth. So again, this is where my frustration came when, again, I check centric, remount this thing, and it's fine, yet the patient is still having issues. So this was our gold standard. And then I want to show you that I went to this. So this is actually a case that I'm taking out of production to show you. So this is VITA Excel anterior, lingo form. And again, you can see that it's not knuckle tight now. If I focus it, you can see it. There's gapping in there, which is good. And then now as I swing around the dorsal end of the articulator, so again, remember the milling teeth that in the milling picture, everything was tight. Well, here it's not. And so that means that there's less chance of interference. And now I want to take the articulator and I want to do this to it. I want to emulate a chew cycle. So now I'm taking the teeth and I'm going not this way anymore because I realize, to me, the person doesn't chew like this. They chew like this. So I'm using the articulator to get me there. Now, regardless of the articulator you have, here's a hinge articulator. Fine. I'm just taking it now, and instead of doing my good old typical what I would do to check the teeth, I am gonna do a chew cycle. So now I just have to hold the articulator differently, but I can still get a chew cycle to check the teeth. Okay, so you can manipulate your articulator. You just have to grab it and manipulate it in the mannerisms that I'm showing you to try and emulate a chew cycle of someone. So what I'm checking for now is these teeth, the 20-degree teeth, were designed to have contact and they have to mill. And the concept of the freedom teeth is that you have a cusp here and it sits into the fossa, and that's what crushes it. And then as this moves, I'm just making sure now, as you can see that red dot move, that's the cusp that's crushing the food. And then it functions within that fossa. So let me just grab a instrument here. It functions within that fossa, and then I'm just making sure it doesn't hit the guiding planes of it. One of the major complaints that I received early in my career was denture patients telling me they can't eat lettuce and they can't chew lettuce. Am I right or am I right? All the doctors and denturists out there are going, yeah, that's right. Yeah, they can't. The patients would just say can't eat lettuce, and I'd look at them and go, well, yeah, it's a denture. What do you expect? And then I realized, Mark, like, look what you're telling someone. Well, okay, too bad. And what do you expect? But then they don't eat it, and now, you wonder why denture patients are malnourished, because they're eating the soft things and not the varied diet that they should be. And I have a lot of patients that are eating nuts because of the health impact and health related benefit of nuts. And it is extremely hard to eat nuts with our good old gold fashioned 20-degree teeth here. I don't have the complaints or the damage with patients eating nuts with what I'm showing you today, as well as I've eliminated the complaint of I can't eat lettuce from my office. And that was a big one. This was about getting a grip on the complaints, understanding what causes the complaints, which meant I had to understand a denture patient, how they function, how they interpret the denture, how they chew with it, how their brain figures it out. And then how am I going to change how I build that denture to that situation? And that's the journey and perspective on denture occlusion that I'm sharing with you today, of why I've drifted and now do what I do. And the benefit of it is that I've reduced the complaint list dramatically, which has made me a lot happier because I'm not dealing with the same stresses as I normally would have at the beginning part of my career. I got a hold of it. It took a while to figure it all out and to implement it. And that's why I am so honored and privileged to share my story and journey with you and colleagues around the world. And I'm so thankful to companies such as VITA North America and VITA Germany that promote this and promote us and to lecture to you so that we can make a difference and be a superhero to the patient. So the big takeaways is freedom and centric, have a wiggle room, make sure that the teeth function within a chew cycle, manipulate your articulator differently to emulate that chew cycle, and see what happens. And what happens is that you are building a denture that will function far better for a patient within their system. So, Jim, do we have any questions? Because I'm slowly kind of wrapping up here of my perspectives of occlusion. I wanted to lay out to everybody why my journey, why I got to where I am today, and why I do what I do and how I do it. And so that now you're left in an hour and a half. I hope to go, huh, okay. And then please let VITA know. I humbly ask that you let VITA know, what do you need from me and from VITA to help you and help you achieve then your goals of trying to reduce your stress levels and be better superheroes to your patients, whether you see them in the lab through a doctor or not, it doesn't matter. There's a patient at the end of this. And to help you try to facilitate it so that you can create dentures that fit a little bit better, function better, and reduce those stresses. And it's just a matter of acknowledging them. So, Jim?
Yeah, let me, thanks, Mark. Let me just follow up a few things. Those of you who asked for CE, we're going to use your registration email address to send you that information. The workshop, the webinar has been recorded. That'll be posted in a couple of days on our VITA North America YouTube channel. So make sure you visit us and watch other Mark Wagenseal programs as well. Here is our direct line for the help desk here at VITA North America, that if you need to, you can give us a call. Mark showed it earlier. Here is the information for the sales representatives. Like Mark indicated, if you watch the video, you can stop it, pause it, and see who your local rep is, or just give us a call here at VITA North America, and we will get you in touch with the appropriate person. We do have additional programs coming up in, this is old, but you know, we have them in November, we have them in December. We have plenty of webinars and maybe workshops in person for 2023. We've also done several, with Mark, several Class 1, Class 2, Class 3 remote workshops that are 2 hours a day, 3 days out of the week, which were very convenient. This is Mark's information here. And then as far as questions, let's start off with Nicole. She's asking, so Vivadent DCLS does not have freedom-centric when designing?
No.
Question mark.
To my knowledge, and again, respectfully, based on the information that I've looked at, the answer is no. It does not. And again, if you find out otherwise, you let me know, because I mean no disrespect to any other companies or anything, certainly not. But to my understanding, the answer is no. that does not incorporate that. It is only Veneris 2 posterior teeth that incorporate freedom and centric, to my knowledge, period, out of Ivoclar.
And another question is, are you aware of or do you know of any digital bite checking device systems such as TechScan, or have you used it to track and document changes in the patient bite pattern, bite force, and so forth?
Yes, so TechScan or MyBite, what they do is they're measuring the occlusal forces upon centric, and then you're watching the distribution load and understanding the distribution load on the tooth based on that information. So yes, they work. It's again, from a denture perspective, I pay more attention, so much not so the end result of the centric contact, but the just before that, there's no hit and slide into the guiding planes. So that's where you have to have the fine touch of understanding the MyBite or TechScan of do they show the deflective contact. They're measuring the pressure change or the weight on it. I'm sorry if I'm using the wrong words, but yes, I'm familiar with that. Yes, I'm familiar with that, but I pay more attention now just how this functions within the chew cycle.
And then an add-on for the chew cycle, there is do you have a good article, book, study that can explain the chewing cycle much better that they can follow up with?
Other than watching my video, so self-servingly, other than watching the videos on the VITA North America website, my videos, because I show a lot of the chew videos, or even this video will contain, the main chewing videos that I have. No, that was all been just research done on me, from me, over the years to understand the chew cycle. But there's also there are some independent articles available, yes, and again, Google is a good resource to look at that and read, but it takes a while to sort through. So no, there's nothing in a book or prepared that we could just hand to you to say here it is finished. But the videos that I've done that are on the VITA North America YouTube channel contain it condensed for you. So some of those videos talk about the hydraulics, and I get more into the hydraulic end of things and what happens internally to the tissues internally. But again, the chew videos, and especially the University of Strasbourg video, that's all available for you to see again online.
All right. So yes, I would highly recommend everybody to go online, VITA North America YouTube channel, go to the VITA section and watch Mark's recorded webinars from the past, because there are sections there that specifically talk about that chewing cycle. This is kind of a two-parter. I'll combine these questions. When you don't have enough anterior posterior length, the room, you remove a molar, remove a bicuspid, and then the other side is, if you're lacking vertical, you try to adjust both the upper and lower saddle areas equal, or do you lean to reduce the upper or lower individually more than the other?
Right. Okay, so that question number one, answer number one. If I have to drop a tooth, I will drop a second premolar or second bicuspid. I will always try to use a molar and a second molar. And even then, I'll use 2 second molars or 3 second molars. I always want a molar. Why? They're bigger. They have a bigger bowl to hold the food and lift it up to the antagonist to get crushed. I want the biggest bowl or fossa possible to take the food up to get crushed against the antagonist. That's number one. Answer number two is then I usually adjust both accordingly. I don't just favor one or the other. If I have to start grinding teeth, I try to grind them equally so that one isn't thinner than the other, etc. I try to do it if I can equally from upper maxillary to mandibular arch.
All right, thanks. what have you found to be the best articulator to use that best mimics human mastication process when setting up your dentures?
Okay, so I use a Cavo Protar 7, but I have attachments on it that actually make it a 9. This is probably, it's like a Stratus 300 ish. Yeah, so from a practical point of view, this thing's probably about 2,200 Canadian, 2,300 Canadian. So I use a Protar from Cavo. Specifically, a 7 or a 9 would get you really into the decent capabilities of an articulator. A Stratus 300 also is decent. And again, and now it's just a matter of which articulator you like and works better in your hands. So that's why I'm going to be careful. I've used Stratuses, and then I used the Cavo ones, and then I ended up this one because I just liked it better. So some people like ketchup on their scrambled eggs, and some people don't. So I like this one because I just like the way it sits on the table. It doesn't come apart. I like it. It for me, it's been a great tool to help. But that's what I use, and I would, again, I would recommend the Stratus 300 or a Cavo 7 or 9.
All right. Jeannie's asking, she wants help to know exactly the brands, the names of the teeth to use. So
I use all my cases, regardless of what I do, regardless of what I get paid for it, gets VITA Excel anterior and VITA Lingoform posterior. And then I adjust the Lingoform to the chew cycle. Even if it's on a government or a social services case or those types of government programs that I get less money for the denture, my chair time is worth way more than extra $50 or $60 in denture teeth. I used to, again, for the first parts of my career, get the cheapest teeth and think I'm cutting corners and saving money. And then I would just waste it in the chair. My chair time is gold. Anyone's chair time is gold. So everything gets done with VITA teeth because it's acrylic glass. It's hard. I don't have to polish it afterwards. This isn't a commercial for VITA. This has been 36 years, almost 36 years of me trying to be a superhero to people. And now using product that helps me get there easier with less stress. That's what I use. It's been good for me.
Another question, more about shade. How do you select your shade, denture tooth shade, if it's a new denture and or the patient's not liking the old denture shade? Is there a method,
right? Well,
your madness of shade selection?
Yeah, so I have the digital version, so I can do it digitally with them and show them, or you have the shade guide that you can put in front of them. But yeah. So what I've done on people that also are a little bit more, they don't know, then I'll do one side one color, one side the other color, or one side their old color, one side their new color. Fine, it's an extra wax try-in, but I just do the upper and I let them see it. I mean, part of this is, again, you see the dress on the, it's like my wife and daughter. You see the dress on the rack. Look, go put it on, because that thing that looks terrible on the rack, you put it on and go, wow, it looks great for me. So to answer your question, we have the shade of the original denture. So then now, what do they don't like about it? What are they unhappy about it? So, okay, typically I want to go lighter. Okay, well, how much lighter? And I can show them lighter ones against their old denture. And they go, well, I don't know. Well, then I'll tell you what, then I'd rather add in that extra wax try-in appointment for 15 minutes than all of the 2 to 5 adjustments afterwards that are running at about a half-hour appointments. From a chair time usage, it's cheaper for me to do that than try to fix it after it's done. So what you can do then is put some different colors in, and then let them see what it looks like in the frame of their face and their mouth.
Great, good suggestion. So last question, have you tried digital Facebook for finding lateral movements and chew cycles? And if you have, what's your recommendation?
Yes, I have a Digma, and gosh, I've done tinkered with all that neat technology. I actually have the old Digma and the new Digma, and yes, Digma's from Cavo as well, so it's the digital articulator, and now there's other companies that are coming out with other digital Facebos. Yes, to be honest with you, and I'm gonna say this, so it's going to be recorded forever. I used those products to understand them and understand their thinking, and then I see how I can use that to my advantage manually by looking at someone and looking at their jaw movements. And so, yes, if you know, I highly recommend them and think they're wonderful in a practice, especially depending on what your practice does. And they have great value, like this thing. This has paid for itself. This articulator sure was expensive, but I'm telling you, it's awesome. It's like the VITA teeth. They pay for themselves in the chair. And so if you're doing very complicated work in implant and implant retained work, then a Digma is certainly, or those types of digital appliances are good for you diagnostically to have. Absolutely. They're worth the investment because, again, you're trying to cut down on the chair time and all the stresses of all the things that go wrong afterwards if we didn't get it right. So yes, I've used them. Yes, I understand them. And yes, they've helped me understand and share with you my perspectives in denture occlusion today. Absolutely. That's why everything that I say is based on all those experiences now, and knowledge of using those products. They're awesome. They'll pay for themselves. It's just, don't buy a Digma if you're only going to use it once a year. But if you have a busy implant practice and you're taking the denture off the ridge, so you're, again, taking away a sensory perception from a patient, then they start to have their value because you're trying to cut down on the adjustment rate.
All right, thanks. So Mark, thank you very much for today's webinar. Greatly appreciate it. It was good information for the attendees, and hope to see you again here in a couple of weeks to do another one, whenever that might be. And then a reminder, everyone, that Mark's webinars are recorded, VITA North America YouTube channel, and we will be putting together the 2023 calendar. I can't believe it's almost the end of 2022. And Mark is certainly going to be part of that. We're going to also try to do some in-person workshops as well in the U.S. and Canada markets. I want to thank everybody for joining us today. Any last words, Mark?
Thanks, Jim, and your team. Thanks, VITA North America, for supporting our professions and helping us be superheroes. Thank you to you all for joining me today, regardless of where you are in North America and the world. Thank you. This is about bettering ourselves and pushing our professions forward in our communities and our neighborhoods and being better and to help somebody. We're here and called to serve to help rehabilitate someone's chew cycle. My tagline always with a patient is your quality of chewing life is number one. And then number two is quality of life, because you have to eat to live. And then everything follows underneath that. And I forgot to tell you this, that patient that I showed you with the really flat teeth that had the implant retained lower and the complete upper denture, she told me afterwards, after wearing the teeth for 4 weeks, she's off a laxative. So she's a patient for life. She's already referred work and patients in. You improve someone's quality of life, that's rewarding and humbling, number one. And number two, that's why we're called to serve, whether you're the technician or a practitioner like myself that sees the patient directly. That's huge. And I've used products now that help me get there, and I'm thankful to VITA, and that's why I've migrated to the teeth specifically. I wanted to again show you my perception and experience in occlusion and why I rethought it, because it's radically different than what I was taught now. I needed that base, but I'm thankful again to have this platform, and thanks to VITA for allowing me and providing this platform so that we can be better and push our professions forward. So thanks everyone for joining me, and thank you for your time, and thanks again to Jim and VITA North America. And we don't slap teeth together.
All right, well said. So thank you very much everyone for joining us. Thank you, Mark, for taking care of the audience, the technicians that had all those questions. And this will end today's webinar.
Awesome. Thanks everybody.